Hello, everyone. I'm Jane Meisel. I'm a breast medical oncologist at Emory University at the Winship Cancer Institute, and I'm thrilled to be moderating our breast cancer case presentation today. I've got an all-star panel here with me, and I'm going to let them briefly introduce themselves as well before we jump into the case.
Thanks, Jane. I'm Reshma Mahtani. I'm also a breast medical oncologist at the University of Miami Sylvester Cancer Center, where I co-lead our breast cancer program.
Excellent.
My name is Dr. Kristin Rojas, and I'm a surgical oncologist at the University of Miami Sylvester Comprehensive Cancer Center.
And I'm Kristina Mirabeau-Beale. I'm a board-certified radiation oncologist practicing in Fort Myers, Florida. I'm the director of our Regional Cancer Center's breast cancer program, and I'm with Genesis Care USA.
Awesome. All right. We've got a lot to cover, so we're going to go ahead and dive into the case. We decided to pick a triple-negative breast cancer case today, and we'll be focusing really on upfront therapy, just because there's so much interesting stuff to talk about here in terms of new data, multidisciplinary care, and just how we manage women in this context, both in terms of trying our best to cure their breast cancer and also their physical and emotional health. So we'll dive right in, lots to discuss. And here's the case. So you have a healthy 43-year-old woman. She presents with a palpable 2.4 centimeter right breast mass. She has imaging done, which reveals 2 abnormal appearing axillary nodes, and biopsy of her right breast mass and her node revealed grade 3 invasive ductal carcinoma that's triple negative. Ki-67 is done on the breast mass, and that's 54%. She's pretty healthy at baseline. She does have diarrhea predominant IBS. She has anxiety. She has hypothyroidism that's well managed. And she has no family history of breast or ovarian cancer, but her mother was adopted and she only has one brother. So she has sort of limited knowledge of her family history. She undergoes staging with a PET scan and has no evidence of metastatic disease. And she's presenting to your office kind of to discuss next steps. So I think, lots to talk about here. We'll start first by sort of talking about this question of, do you go to surgery first, or do you go with neoadjuvant chemotherapy or neoadjuvant chemotherapy plus immunotherapy? Before we dive into the systemic therapy piece of it, I'm going to ask Kristin, our surgeon on the panel, to talk to us a little bit about neoadjuvant chemo versus surgery first and kind of how you would approach that question in this patient.
Thanks, Jane. I think that this is a really critical question because oftentimes these patients do see the surgeon first. And if we could just advance to the next slide.
Oh.
Perfect. So, and starting with or making this decision in these triple negative patients or even HER2 positive patients or locally advanced ER positive, HER2 negative really does require a multidisciplinary approach. With or without a pathologic complete response, there is benefit to surgical downstaging. And I think we kind of lose this sometimes because we always talk about path CR. We know that probably between 70 to 90% of patients who are not eligible for breast conservation become lumpectomy candidates with neoadjuvant chemotherapy, and triple negative status actually increases that likelihood. With the advent of oncoplastic procedures, even patients with large T2 tumors can undergo complex rearrangement techniques at the time of surgical resection. And oftentimes we can even combine a mammoplasty or a breast lift to minimize volume defects associated with large resections. Over time, with increasing targeted therapy, the path CR rates in both the breast and the axilla are continuing to increase. And I know that some of my colleagues are going to talk about that today. But a more recent development from a surgical perspective that I wanted to highlight is the ability to offer patients less morbid axillary surgery with preoperative therapy. And so even patients with biopsy-proven node-positive disease who have a good clinical response by exam or imaging can be offered a sentinel node biopsy. And just as a side note, sentinel node before chemotherapy is actually no longer standard practice because you don't take advantage of this potential downstaging, and we actually don't know the prognostic value of negative nodes after neoadjuvant if we remove the only positive node before chemo. And so in this patient with triple negative disease, she has at least a 50% chance of converting to a nodal path CR. And so therefore, I'd really favor preoperative therapy for her because we could potentially defer axillary dissection, minimize morbidity associated with dissection like lymphedema, cording, and mobility issues. And then I also advocate for placing a clip at the time of biopsy, especially in triple negative or HER2 positive patients, because they often have such a robust response to chemo that those nodes will become small and much less easy to identify at the time of surgery. outside of the benefits of chemotherapy and immunotherapy, which we're going to talk about soon, chemo also allows for time for the complex surgical decision-making conversation. Patients oftentimes come to me requesting a double mastectomy from the beginning. And I think this gives time for patients to kind of have that sink in, and for us to explain that most of the time bilateral mastectomy is not going to change their oncologic outcome. But in patients who do require mastectomy, it also allows additional time for those patients to weigh their complex reconstruction options.
Yeah, and that's a really good point. I think, sometimes the knee-jerk response is, I've got cancer, take it out. But there's so much that can be gained from kind of putting off the surgery and allowing time to see how people respond to upfront therapy, but also seeing, giving people time to understand their surgical options, to do genetic testing, as you said, and of course, the ability to sort of plan what we do after surgery in terms of optimizing cure rates for triple negative disease is really important. So I agree. I think certainly upfront chemotherapy or upfront systemic therapy would be what I would recommend for this patient. Reshma and Kristina, do you guys have any other thoughts about that?
From our perspective, I think it's really going to be important to discuss some of the new additions that we have to our armamentarium in terms of improving path CR rates, and that's going to be a nice segue into our discussion on immunotherapy.
Yeah, absolutely. So we can just dive right into that. I think, one of the things we talked about is path CR rates. And as Kristin said, upfront chemotherapy can be helpful, in terms of the knowledge that we gain from chemo, even if patients don't get a path CR. But one of the things that's really important for triple negative patients is that if you don't get a path CR, your outcome ultimately is likely to be much less optimal. And so it's useful to know, who's going to get a path CR so that we kind of can help patients understand, what is your outcome likely to be in the future? How likely are you to have recurrence? So that then we can help people understand what their options are for more treatment after surgery, and also what their risk is likely to be.
And I think it's really helpful to, as you point out, Jane, to explain it to a patient, because one question that we get quite a bit in the adjuvant setting as a medical oncologist is, how do I know that the treatment that I'm receiving is quote unquote working? And it's a very easy discussion when you can explain to them that you're feeling an improvement on exam or seeing radiographic improvement. I think it sits well with patients.
Yeah, like the idea that you're actually watching something shrink before your eyes is a lot more reassuring than taking it out and then not knowing if you've killed off microscopic cells or not, for sure. Yeah, and I think, this is part of why neoadjuvant chemo has become the standard of care for all but the smallest tumors. As you can see here, this slide, I think, shows really nicely in the dark blue and in the red that if you have a path CR and you've got triple negative breast cancer, you really are likely not to do very well. So, if you have no path CR and you've got triple negative breast cancer in the red, you're really not likely to do that well. But only 68% of patients will be alive at 3 years in that group of patients. And so the question is both, what do we do to improve path CR rates, to improve survival rates, and then how do we get more patients into situations where they can do neoadjuvant therapy up front? So, as we've said, this is an area of great need. Path CR at this point occurs in about 30% of patients with triple negative breast cancer, and we'll talk about how immunotherapy may be changing that. The risk of recurrence is very high for those who don't achieve it. And if you develop metastatic triple negative breast cancer, your prognosis is very poor. And so, a lot of research has been put into and is still being put into understanding what's driving triple negative breast cancers. They may not all be alike, and we may need to learn more about, who's likely to respond to which treatment and who might be more likely to respond to a different treatment. And the development of targeted therapies for triple negative breast cancer really is kind of a holy grail. So lots of different novel targets, and many of you may have seen a slide or something like this before. Some of these treatments are already being put into play in metastatic triple negative disease. We have PARP inhibitors available for patients with BRCA mutated breast cancer. We have antibody drug conjugates such as sacituzumab govitecan that have really made a big difference for patients with metastatic disease. And then, of course, immunotherapy. So a couple of immunotherapy agents that we have talked about in the metastatic setting, and then most recently, pembrolizumab in the upfront setting. So what's the rationale for immunotherapy in triple negative breast cancer? One of the things is that triple negative tumors tend to have a higher mutational burden than HER2 positive or hormone receptor positive tumors. And this can lead to a higher frequency of immunogenic mutations and can be a marker of improved survival after immunotherapy across multiple tumor types. And there have been pathology studies showing also that there are higher mean quantities of tumor infiltrating lymphocytes in triple negative breast cancer compared to other subtypes. And this also may correlate with improved survival, reduced recurrence, better response to neoadjuvant chemo, and then potentially a better response to immunotherapy as well. And then triple negative tumors also tend to have a higher rate of PD-L1 expression relative to other breast cancer subtypes. So it's a good potential target for anti-PD-1 or anti-PD-L1 therapies. So this is, obviously an interesting rationale, and like the science makes sense, but sometimes the science can make sense and it doesn't necessarily make sense clinically. But in this case, we have some data to support the use of immunotherapy in this patient population. So Reshma, I don't know if you can walk us through the recent study that led to approval of pembrolizumab in the upfront setting and talk about kind of how we use this and how we put this data into play in clinical practice.
Sure, happy to. So in the next slide, we'll see the schema for the Keynote 522 trial. And this is a very important study. It led to the recent, just hot off the presses, FDA approval in the neoadjuvant setting for pembrolizumab in combination with chemotherapy for patients with high risk early stage triple negative breast cancer, and as a single agent in the adjuvant setting to be continued after surgery. So as mentioned, this was a fairly large trial of over 1,000 patients with stage 2 or 3 early stage triple negative breast cancer, and patients were randomized 2-to-1 to pembrolizumab versus placebo in the neoadjuvant setting, with both arms receiving the same chemotherapy backbone. The platinum was carboplatin, given either on a weekly or every 3-week schedule, along with weekly taxane, followed by anthracycline-based chemotherapy. And then after surgery, patients who were randomized to the pembrolizumab arm went on to receive additional treatment for 27 weeks with pembro, and the other patients continued on placebo. So in our next slide, we'll see the baseline characteristics of these patients, and not surprisingly, these were a younger group of patients in terms of median years of age than we usually see in breast cancer studies, recognizing that these were triple negative patients, and we tend to see this subtype in younger patients. About 80% were PD-L1 positive in both groups, and again, as I mentioned, the carboplatin schedule is shown well balanced. About 50% of patients had nodal involvement. Next slide. So the primary endpoint of PCR was previously reported at the first interim analysis, and you see in the graph to the left, you see a delta of 13.6% in favor of the pembro arm in terms of increasing PCR, but the event-free survival that was originally presented at the first analysis, and just to make sure we're all on the same page with regards to the definition, it's defined as the time from randomization to the first occurrence of disease progression that precluded definitive surgery, a local or distant recurrence, a second primary cancer, or death from any cause. And at the first event-free survival analysis, this was not a significant finding. Next slide, please. So more recently, we saw at the fourth interim analysis a statistically significant and clinically meaningful event-free survival difference, again favoring the use of pembrolizumab. And this was, in terms of events, 15.7% versus 23.8% in the pembro, or in the placebo arm, rather. So in a pre-specified exploratory subgroup analysis, the 3-year event-free survival benefit was seen independent of PD-L1 expression, which is not shown here, but here what is shown is it was also independent of the achievement of a path CR. So following a pathologic complete response, event-free survival was 94.4% with pembro plus chemo and 92.5% with placebo plus chemo. And without a path CR, the rates are shown here, 67.4 versus 56.8. So what's really notable here is that patients with residual disease have a substantially higher event-free survival if treated with pembrolizumab. And for patients who achieve a path CR, there is a benefit to pembro of about 2% here, suggesting that this benefit might be irrespective of the achievement of a path CR.
Wow, but yeah, but that, that 11% benefit that you're seeing in the non-path CR group, especially because that's such a high risk group, is really,
yeah, very, very impressive.
Yeah, definitely. That's great.
And then in terms of distant progression or distant recurrence-free survival, unfortunately, the events by category unfortunately showed that the majority of these were distant recurrences. And again, here you see the events being higher in the placebo plus chemo arm versus the pembro arm. Again, a statistically significant finding. Absolutely.
Yeah. So that's a significant number. So essentially what this is saying is that 20% of people are having a non-curable recurrence by 3 years. That's
correct.
Correct. Finding for sure.
And it tells us the prognosis of these patients just in terms of the aggressiveness of their disease and the unmet need that we have here overall.
And all these patients were getting carboplatin. So these patients, even if they weren't getting pembrolizumab, were getting a pretty aggressive neoadjuvant regimen.
Correct. And then in the next slide, we see overall survival, which is currently not mature, but we do start to see separation of the curves. So definitely there is a need to continue to follow this data set. So here I included a summary of neoadjuvant studies of chemotherapy plus or minus a checkpoint inhibitor in triple negative breast cancer. And I'm certainly not going to go through all of these different trials. I just included them to show you some of the differences with regards to the use of the chemotherapy backbone, platinum, yes or no. And one point that I just make is that I think there are still certainly outstanding questions, and I'll just highlight the Gepard Nuevo trial that's shown in this table, which evaluated durvalumab and placebo when given in combination with an anthracycline taxane chemo in the preoperative setting. And this was a bit disappointing because we didn't see a statistically significant improvement in path-CR using the IO, although there was a numerical improvement. It didn't reach statistical significance, but not shown here were data that we did here at ASCO evaluating long-term outcomes with a caveat that that was a very small study. It wasn't powered to look at long-term outcomes, but intriguingly, there were large differences in invasive disease-free survival, distant disease-free survival, and overall survival with adding durvalumab to chemo, which means that even though we didn't see an improvement in path-CR, we did see a difference in long-term outcomes. So one question that comes to mind as we try to reconcile these data sets is whether PCR is actually the right endpoint for an IO study, which is different than what we know about chemo in this setting, and other unanswered questions, again, with regards to the chemotherapy backbone. Do all patients need anthracycline, taxane, and platinum? Do we have a biomarker for who to give the therapy to, understanding that immunotherapy does have some toxicities that can be lifelong. And then finally, I'd say what to do after surgery is definitely a consideration, because one of the things that we noted when we looked at the schema of KEYNOTE-522 is those patients that received the pembro up front went on to receive it in the adjuvant setting, regardless of whether or not they had a path-CR. So should we adapt the use of the immunotherapy in the adjuvant setting based on the response to neoadjuvant? That's an unanswered question, and I think we have ongoing trials that will hopefully give us some direction in that regard.
Yeah, I do think there's so many, this is such a huge step forward for women and for the whole breast cancer community, and definitely some questions that are unanswered and some ways in which we will have to continue to individualize treatment for patients. I think another interesting point is with I-SPY 2, the data was presented several years before KEYNOTE-522, and that trial did not include the adjuvant pembrolizumab and also did not include platinum, but patients still did a lot better with the addition of pembrolizumab only to the taxane part of the dose-dense ACT. So you have to wonder, what is the optimal amount of pembrolizumab? What is the optimal treatment schedule? And sometimes you have to adapt based on, patient response, patient tolerance, and all that stuff. But I think there is definitely something to be said for chemoimmunotherapy together, and maybe the combination kind of stirring up antigens that allow the immunotherapy to work better. I think we'll know so much more as time goes on. But I am particularly intrigued by the fact that the patients who didn't achieve path-CR in KEYNOTE-522 did so much better in terms of their overall outcomes, having gotten the pembrolizumab, really suggesting that there may be something beyond path-CR that we need to look at to help determine prognosis for these patients. So probably lots more to come in the next couple of years, but definitely an important step forward. So this patient, just back to our woman, gets ready to start neoadjuvant chemoimmunotherapy. I think, based on the data that Reshma presented, it's, felt that this is the appropriate regimen for her. And so she prepares to begin treatment based on Keynote 522. She gets her port placed, she gets her wig prescription, she gets ready to go. And I think, one thing to highlight is that there are some important things to consider at this juncture. And for any woman, especially young women who are, newly diagnosed with a triple negative breast cancer and are getting ready to start on such an intensive protocol, there's a lot to think about. I think, the mental health concerns we can talk about more a little bit later on in this case, but are huge. Making sure people feel supported, making sure that particularly in an era of COVID where people may be a little bit more anxious and a little bit more depressed and a little more isolated, that those needs are being met. But then also some things that, were around before COVID and are going to be around after. Fertility concerns are huge. A lot of women, particularly with triple negative breast cancer, may not yet have finished completing their family. And so making sure they understand that chemotherapy may impact their ability to complete their family naturally, and they may need to think about things like fertility preservation prior to chemotherapy. It can be important. And sometimes that can be done by, urgent referral to reproductive endocrinology. And while they're getting their port placed and having their scans done, they can be actually harvesting eggs and going through that process if they need to be. So I think addressing those concerns proactively, even though it can be a hard thing to talk about, is really critical. And then genetics, I think with triple negative breast cancer, this is becoming more and more of a concern because a fair number of our triple negative breast cancer patients will turn out to be mutation carriers of BRCA1 and BRCA2, even if they don't have a family history. So we are recommending more and more genetic testing for patients with triple negative disease, because this can increasingly impact what we do for patients in terms of their surgical options. If you have a mutation in BRCA1 or BRCA2, you might be much more inclined to consider a bilateral mastectomy, and then also potentially options that we'll talk about later for additional treatment in the adjuvant setting. So I think those are some of the main things to think about as you're counseling patients on their way to starting a neoadjuvant regimen. Anything else that you guys can think about that you would want to highlight here as this lady is getting ready to start her treatment?
No, I think you touched on all the major ones, Jane.
All right. So she undergoes genetic testing in this case, and she is BRCA1 positive. So she starts her chemotherapy, her dose-dense AC and pembrolizumab, and then her carbotaxol pembrolizumab. So she has a good clinical response. Halfway through the carbotaxol pembro, which is how the regimen sort of starts out with Keynote, and her regimen was designed based on that, she has neutropenia, which causes a chemo delay. So Reshma, tell me a little bit about, and I don't know, I've, since this regimen was approved 4 weeks ago, or 5 weeks ago now, I've only had a chance to start it in a handful of women, maybe 2 or 3. But tell me what your thoughts are on both carboplatin dosing. Do you do it weekly or every 3 weeks? And then how you manage the neutropenia. I would love to just chat about that a little bit before we move on.
Sure. So one thing that I do in terms of your second question about managing the neutropenia is just being proactive and letting patients know that this is likely to occur. We know that combination chemotherapy increases hematologic toxicities. And I think for patients, the most one of the most difficult things, I think, for women who are going through early stage breast cancer, especially younger women who might be balancing childcare and work issues and everything else, is planning out their time in the chemo center, in the chemo unit rather, and knowing that they may come in and be turned away because they're neutropenic and it's not safe to administer chemotherapy, and just giving that information up front to them so that they're not surprised by it. In my practice, I generally do weekly carbo dosing as opposed to Q3 week dosing. I find that it's a bit easier for patients to tolerate, and also tends to result in less neutropenia and dose delays. Has that been your experience as well, Jane?
Yeah, that's been my experience as well. And I had used, some carboplatin paclitaxel in my neoadjuvant regimens prior to the approval of immunotherapy. And I had found that as well, that with the weekly carboplatin, it was easier to tolerate, both in terms of like side effects such as fatigue and nausea, but also in terms of neutropenia. And I agree with you. I think, helping patients understand the risk of neutropenia and other cytopenias as well. But this is something we expect, and like trying to help them make plans that allow them to be as flexible as possible so they're not devastated if they get turned away, I think is key. And then also just from a logistics standpoint, getting Neupogen approved as early as possible, just so that if we need to give growth factor for a couple of days in between treatments to allow patients to keep their counts up, we can get that taken care of for them. I completely agree. I think, when women are trying to manage multiple things outside of chemotherapy, which in and of itself can be a full-time job, it can be devastating if you get turned away and then you have to come back a different day. So doing everything we can to help people both, plan for flexibility if possible, but also prevent them from having to be turned away from chemotherapy is very helpful. So this patient, she uses filgrastim twice a week for the rest of her regimen, is able to complete her treatment, and then she goes on to surgery. So Kristin, maybe you can talk us through a little bit about surgical planning and kind of what you think about here, both in terms of just surgical planning in general for a BRCA positive patient and for a patient receiving neoadjuvant chemotherapy for a node positive triple negative breast cancer, and then also any additional concerns you might have given that this woman has been receiving immunotherapy.
Yeah, so with regards to surgical planning, we know that neoadjuvant therapy does not confer an increased risk of complications. And so the optimal timing with reconstruction is about 4 to 6 weeks. It gives us a pretty significant window in the event that patients are having issues with their counts. We have a little bit more flexibility. If a patient's getting reconstruction, most plastic surgeons prefer not to operate on them before 3 or 4 weeks after chemo. With regards to choice of surgical procedure, lumpectomy versus mastectomy in a patient who's not BRCA positive, receipt of neoadjuvant therapy can even kind of downstage a patient in the mastectomy setting. And what I mean by that is in patients who are going to have a mastectomy, if the tumor is close to the skin, it can shrink it away from the skin and make them eligible for a skin-sparing mastectomy or nipple-sparing mastectomy. And then that also changes their reconstruction options, potentially making them a single-stage procedure instead of tissue expanders to implant. With regards to contralateral prophylactic mastectomy, in the United States, there's an increasing rate of CPM in non-mutation carriers with earlier stage disease. And there's actually a big movement among surgeons to try to reverse this trend. And nevertheless, it should be offered to patients with higher penetrance gene mutations like BRCA1 and BRCA2. But I actually still offer patients breast conservation or unilateral surgery if they're appropriately counseled, if I know they're going to be coming back for surveillance, especially if they're older, BRCA2 positive, but ER positive, and I know they're going to be getting adjuvant endocrine therapy that would decrease the risk of contralateral cancer. So in the setting of without a genetic mutation or negative genetic testing, the guide I offer, the breast conservation or mastectomy, really try to tailor it based on their cancer and kind of steer patients away from CPM in that setting. In the setting of moderate penetrance genes like CHEK2 and ATM, guidelines don't recommend routinely doing contralateral prophylactic mastectomies for those patients. And we, in our practice, do approach these on a case-by-case basis, balancing the risk of complications, potential treatment delays, patient comorbidities, and their age, and their willingness to continue screening. And lastly, regarding reconstruction options, immediate reconstruction results in better patient satisfaction. And this has been shown. There are different options for reconstruction, including not only implanted autologous tissue, and even if post-mastectomy radiation is planned, you can offer both options, but this is where our plastic surgery consultation and our radiation oncology consults, which is another option to more information to give patients while they're getting neoadjuvant chemo. This is where the multidisciplinary collaboration really comes into play. And so during neoadjuvant chemotherapy, patients may meet with either the radiation oncologist or plastic surgeon multiple times to really discuss all the complex decision-making involved.
Yeah, no, I completely agree. And that's a great overview. One question I would have, just because practically speaking, I think a lot of us have had the experience where, patient who is young, doesn't have a BRCA mutation necessarily, but is just so scarred by the fact that they've had this cancer that they're like, I just want you to remove both of them. I never want to get a mammogram again, bilateral mastectomy. How do you sort of, if you feel like maybe that's not the best option for them, how do you sort of talk them through those feelings?
Yeah, well, we actually have a couple of different ways. Number one, by explaining that it doesn't change their oncologic outcome, but I do always need to discuss what screening in the future is going to look like. These patients are often recommended to have surveillance MRIs in the future. And we don't know what the long-term effects of gadolinium deposition over years and years of MRIs. So, specifically in our patient population in Miami, that it's a very young patient population where I know they could potentially be getting screened for 50 years. That's definitely something to think about. I do have, oftentimes it kind of fixes itself because patients will go meet with plastic surgery, hear that it's often can't be a single stage procedure, that they're going to need multiple surgeries, and they kind of steer themselves away from that decision. I also, we have a mentorship program where we can connect patients with other patients who have had similar procedures, maybe young patients who have small children, et cetera. And I really try to impart to them that their life is going to look a lot different if they have a bigger surgery that they may not need. And also, lastly, it's important to clarify with them that just because I do a mastectomy doesn't mean that I can make the risk of recurrence zero. That's a really common misconception. They think if it's gone, that the risk of recurrence is zero. And so I think it's important to really be clear about that.
Yeah, no, I think it makes a lot of sense. It sounds like a very good way to talk people through it. Perfect. Let me just move on to your next slide. So axillary management, I think this is such an important conversation. I'm looking forward to hearing what you have to say here.
Yeah, so a really hot topic. And so in the past, patients who presented with biopsied node positive disease would have necessitated an axillary dissection. And we know the benefits of sentinel node biopsy in the setting, the non-neoadjuvant setting. We know that it works. We know that false negative rates are low, and we know that the rate of lymphedema is also lower. But post-chemotherapy, there have been concerns about the ability to identify the sentinel nodes after systemic therapy, since we don't know if chemo has a uniform effect on all nodal metastases or how chemotherapy alters lymphatic drainage. And so 3 large trials sought to determine the feasibility and success of sentinel node after neoadjuvant chemotherapy. And this was the ACOSOG Z1071, Sentina, and then the Canadian FNAC trial. To summarize, the nodal PCR rates ranged between 35 and 50%. And by they were able to minimize the false negative rate to get below 10% by limiting sentinel node biopsy to patients who converted to having a normal exam using dual tracer, so both radionucleotide and blue dye, and retrieving at least 3 sentinel nodes, which would bring the false negative rate to below 10%. And additionally, in a study by MD Anderson that looked at outcomes after targeted axillary dissection or sentinel node biopsy with retrieving the clipped node, they found that the clipped node was actually in a non-sentinel node about 20% of the time. So if you have the ability to identify the clipped node and retrieve it, that brings that false negative rate even lower. With regards to patients who start as clinically bulky nodal disease or N2 disease who are super responders, consensus is still kind of pending on these patients, and we really also approach those as a case-by-case basis and reviewed our multidisciplinary meetings.
Yeah, I think it's always so important to talk about what we know and what we don't know. And if someone's falling into a zone where we don't have, obvious data to back up what our approach is, just kind of talking about risks and benefits and what they prefer and kind of, what they can live with. Because I think there's a lot of nuance to these conversations for sure.
Yeah, and for those patients that do have residual disease, specifically, we do need to do a complete dissection for patients who fail mapping, so where we can't identify sentinel nodes, or we're not able to retrieve enough nodes, or we can't find the clipped node, and then with any positive disease currently. So that includes isolated tumor cells or micromets for now. So we know that in the upfront surgery setting, a low axillary burden does not necessitate an axillary dissection, specifically after the ACOSOG Z11 trial, which looked at patients with 1 to 2 positive nodes, randomized either axillary dissection or radiation in the breast conservation setting, and found that overall survival was similar. With residual disease after chemotherapy, that's a little bit of a different situation. And until we have the results of the Alliance trial data 11202, the recommendation is to dissect those patients, even with a low burden of residual disease, because the risk of additional disease outside of the sentinel nodes is just unacceptably high. And so for those patients who do require an axillary dissection, there are ways to primarily prevent lymphedema now, and different surgical techniques ranging from axillary reverse mapping, where we inject a dye in the upper arm, identify the lymphatics coursing through the axilla, preserve them during sentinel node or axillary dissection, or more involved procedures such as S-lympha or lympha, where we identify those lymphatics and then actually reconnect them to spared collateral venous collaterals that we identify in the axilla. This brings that lymphedema rate down from greater than 30% when axillary dissection radiation to about 10%. So it makes a huge impact if you're available to offer these to your patients. And those patients that do have axillary dissection or multimodal therapy, which is a risk factor for lymphedema along with high BMI, early intervention really is key to preventing the long-term sequelae.
And by early intervention, do you mean like physical therapy and that kind of thing? Or what do you mean by early intervention?
Yeah, so in the conservative setting, physical therapy, getting them fitted for a sleeve, and then in some centers, even able to offer procedures with microsurgical procedures to reverse lymphedema, which is still in its early stage, but shows a lot of promise for the future.
Mm-hmm. And is the idea that if you do something like that, doing it earlier is better?
Definitely.
Yeah, very interesting. So many things to consider. Excellent. So this patient undergoes bilateral mastectomy because she's BRCA1 and because she's young, I think is part of the reason why that decision was made. And happily for her, she's found to have no evidence of disease in the breast. She has 7 axillary nodes removed, 2 show treatment effect, but none with residual disease. So she has achieved that pathologic complete response. Very exciting. So she continues on her pembrolizumab and makes plans for radiation therapy. Now, ideally, she's been talking to her radiation oncologist all the way through and has a pretty good sense for what that's going to entail and how it's going to, kind of interact with her reconstruction options. But Kristina, maybe you can tell us a little bit about, kind of what are some of the things you think about here, both in terms of the bilateral mastectomy, reconstruction timing, and reconstruction technique. And then what are you thinking about for this patient who's been on immunotherapy and is probably going to continue on immunotherapy as per Keynote 522?
Absolutely. So, a lot of different interesting nuances that are kind of evolving, and it's very important for the radiation oncologist to kind of remain at the multidisciplinary discussion, just because we're in a lot of uncharted territory kind of across management. So, this slide is from a review from Cancer that kind of looks across disease sites at the interaction between radiation and different types of immune checkpoint blockade. And really, at a more fundamental level, when we think of, how is radiation interacting with immunotherapy, we know that radiation therapy has a local cytotoxic effect that basically causes cell death. And then that releases tumor antigens that can then activate T cells and promote migration of tumor infiltrating lymphocytes. And, it also can lead to increased, immune response through changes in the tumor microenvironment. And that leads to obviously a lot of interesting considerations regarding immune checkpoint blockade as well as radiation. And even across different disease sites, we see a lot of different kind of sequencing regimens across disease sites, and that's becoming an evolving paradigm across disease sites. So, whether we have immunotherapy first, and it's more of a primer to try to initiate host response and avoid kind of the overlap with concurrent radiation therapy. But then we're also seeing other disease sites where radiation is done concurrently with immunotherapy, and then even in the adjuvant setting. So, in a lot of ways, this is a changing paradigm, and it involves a lot of it with an understanding of the basic science and also an understanding of kind of the side effect profiles and how those affect patients kind of going forward. So on the next slide, going back to more specifically breast cancer, this is kind of a busy figure, but it's from Up to Date and it has a lot of the algorithms that kind of Kristin so nicely summarized in terms of basically, de-intensification of management of the axilla in the context of neoadjuvant therapy for lymph node positive patients. And essentially, it's a lot of, branch points, but basically all roads when you initially present with lymph node positive disease kind of lead towards axillary radiation. The goal is to minimize kind of dual insults to the axilla. So, the maximal morbidity being associated with, completion axillary dissection followed by comprehensive nodal radiation. And so ideally we have sampled the lymph nodes as we had in this case to make sure we understand the patient's pathologic nodal involvement up front, and then we can track her response after neoadjuvant therapy. But then in this patient, for example, where we're able to see she has a robust clinical response, it's exciting that we're able to really de-intensify the surgery. And Kristin touched on kind of the false negative rates. So I think a key thing is really things like the dual mapping procedures, making sure that we're adequately sampling the clip nodes. and ensuring that we're getting an adequate sentinel node biopsy. But then even for these patients, they generally do require comprehensive nodal radiation therapy to ensure that we're fully eradicating any microscopic disease. So on the next slide, kind of getting more into radiation and immunotherapy, only had a handful of patients kind of treated per keynote, obviously, since this is pretty new stuff. But usually, we've held off on the immunotherapy during radiation and then restarted it about 2 weeks after completion of the patient's radiation therapy. And I'm curious how your institutions are kind of handling the sequencing as well. When it comes to side effects and certain key interactions, we often talk about radiation pneumonitis and how can we even tell the difference between radiation pneumonitis in these patients versus immune-mediated pneumonitis, and that can be challenging radiographically. A lot of times it has to do with kind of the time course, and then also kind of the appearance on scans. So classically, we think of radiation pneumonitis when it's more kind of in the field of treatment as opposed to diffuse. And also the timeline. So especially if we're looking at these changes within 6 weeks to 6 months of completion of radiation, tend to think of that more as a radiation mediated response. Whereas if we're looking at patients kind of greater than 6 months from completion of their radiation, then we think that more may be related to the immunotherapy. We've seen this from even the adjuvant chemo data in terms of sequencing radiation and rates of pneumonitis in that setting. So for perspective, when we start radiation therapy kind of closer to the last cycle of paclitaxel, for example, you can see rates of radiation pneumonitis is greater than 15% if we start too soon, too close to the last cycle. However, if we're able to kind of delay radiation to at least the 3 to 4 weeks after the last cycle of chemotherapy, then the rates of pneumonitis drop down to between 1% and 5%. So we try to make sure that the interval from completion of chemo to radiation is greater than 4 weeks. And we're figuring this out kind of as we go right now with immunotherapy. And then in terms of the management, generally for radiation pneumonitis, we would use a steroid taper versus if it's related to the immunotherapy, we would generally stop immunotherapy. So I'm curious, what are you guys doing in terms of your institutional practices, just in terms of the sequencing and timing with radiation?
Reshma, do you want to comment on that or do you want me to start?
You can start.
Sure. I think, it's interesting because it is all so new and we don't actually have patients yet who have completed a course of carbotaxol, AC, and with pembrolizumab, and then have gone on to radiation. So I think those practices are still evolving just because from the time course, it hasn't been long enough to sort of see a patient through treatment and through surgery. So it's a really interesting question. I think, as I'm thinking about it, as you were talking, we've had patients in the metastatic setting who've required radiation for one thing or another and who have been on immunotherapy and we have not held immunotherapy. And there is also that data, looking back at like the melanoma trials and lung trials showing actually maybe even some synergy between radiation and immunotherapy. Although then there's this radiation pneumonitis question that is, as you said, hard to differentiate between immune-mediated pneumonitis and radiation pneumonitis. So definitely a question that I think we'll have to continue to discuss as time goes on. And maybe it also comes down to kind of discussing with patients some of the risks and benefits.
I was just going to add, I was just going to add a similar comment in that, as breast cancer oncologists, we have lagged behind a bit in our understanding of immunotherapy in comparison to some of our colleagues who treat other tumor types. And this is an evolving area, especially given that many of us are using immunotherapy or had used immunotherapy in the context of clinical trials and not really in practice until we now have an approval. So definitely we have much to learn here.
For sure. No, it's an exciting area, but also an area where there's lots to learn. Well, that's great. Kristina, I'll let you go on to talking about PMRT.
Well, not to fractionation. So in patients who are treated in the preoperative setting, remember, adjuvant radiation is based on the maximal extent of disease. So their clinical stage and pathologic stage and tumor characteristics kind of at diagnosis pre-systemic therapy. And our standard for the longest time has been 6 weeks of radiation therapy to the chest wall in the post-mastectomy setting, including the regional nodal fields. However, there's actually a recent meta-analysis looking at over 25 trials that included over 3,800 patients who received post-mastectomy radiation therapy and actually compared our conventional course over 6 weeks with shorter courses of radiation therapy, so 3 or 4 weeks of radiation, and actually showed no significant difference in overall survival, acute skin toxicity, late skin toxicity, and lymphedema or cardiac toxicity between the two dose schemas. So, If you ask a lot of community radiation oncologists, there is some apprehension about doing a shorter course of radiation therapy in the post-mastectomy setting, just because of kind of limited follow-up. And then especially in cases like ours where the lady is undergoing reconstruction, there's just limited data right now about shorter courses of radiation in the post-mastectomy setting in the context of a reconstruction. However, this is the subject of ongoing investigation. So I wanted to mention the RT-CHARM study, which specifically is looking at hypofractionated post-mastectomy radiation therapy in women who are undergoing breast reconstruction. I think for patients who have more favorable biology, so, for example, your older patients who have estrogen positive disease, I've definitely shifted my practice to offering more short course post-mastectomy radiation. But in young patients, such as our index case here, there is growing data that you can safely offer chest wall radiation as well as to the comprehensive nodal fields with shorter courses. And I've started doing that as well.
Got it. Yeah, it is definitely an evolving field. And it does seem like, for some of these more aggressive biologies like this patient here, if we're doing more with regards to systemic therapy, which it seems pretty clear from existing data and evolving data that we are going to be doing more for these patients, maybe there is room, if the data shows that there's room to cut back on some of the local therapy, like the radiation afterwards. So, as we've said, an evolving field, but a lot to learn and a lot to be learned from these cases. That's great. So this patient completes her radiation. She continues on her pembrolizumab, and then she comes into the office asking about capecitabine and olaparib, both of which she's read about in one of her Facebook groups for triple negative breast cancer. So I threw that in there both because I think it's important to talk about capecitabine and olaparib and what we, all the options that we have for patients in the adjuvant setting, who's eligible for what, and how we would offer these out, particularly in patients who've had pembrolizumab neoadjuvantly and are now going to be getting it adjuvantly. But also this question of, there's a lot going on in social media and a lot of very knowledgeable patients out there, but also a lot of information out there that patients can latch onto and can read about and may come to you asking about, or may not come to you and just, seek out like supplements and things like that. So this is one of those classic scenarios, but I would just kind of open for discussion before we talk about capecitabine and olaparib specifically to ask, how do you guys, kind of handle this when people come to you and say, I've come up with this idea from my support group or from Facebook, or I read this article about this, drug that's being studied in mice. How do you kind of navigate some of those conversations? And any of you can take that.
I can start.
Yeah.
I think one of the things that that's really difficult for women who are diagnosed with breast cancer is this feeling of vulnerability and not being in control of what they receive or how they're going to do. And with all good intentions, they turn to Dr. Google to try to get some control over the situation. And I always spend time listening to patients to hear what they've read about and understand, what is it about that treatment that might be of interest to you. But I think the most important thing is to redirect patients when they're getting to sources that are not reliable sources, providing them reliable sources. And as Kristin mentioned, we have a wonderful mentorship program at Sylvester where we actually take patients who have gone through similar situations and sort of buddy them up. And I think that's really helpful because I think patients lose sight of the fact that breast cancer is not one disease, and what their neighbor or their friend or their family member who with all good intentions is telling them, well, I only took a pill, or I didn't need chemo, why do you need it? It's with all good intentions, but it may not be applicable to the situation that they're going through. And I think that's a really important point to drive home.
Yeah, no, I completely agree. And that's so well said. I do think one of the hardest things for people is exactly what you said, like having cancer at a young age or at any age means you kind of have lost control over this situation. And one way to sometimes regain control is to, take control over what little piece of the puzzle you can, and really understanding why we're doing what we're doing, I think is key. And sometimes I think you can alleviate some of those anxieties by just really explaining why we're recommending exactly what we're recommending for them. And then, why we're not recommending other things. And I think, certainly there's a lot of direct to consumer advertising. There are a lot of, groups on the internet. So there's a lot that we have to contend with. But I think, allowing people to take control where they can, over things like nutrition and exercise and, the stuff that they can do to help themselves is helpful. And then sometimes talking them away from, things that maybe they don't need as much of. But definitely an ongoing conversation. Kristin or Kristina, anything else to add to that before we talk a little bit about these other drugs?
I think just acknowledging and validating, kind of whatever concerns or new information the patient brings to your interaction, just because, there can be a moment of, education if they either introduce a new, technique, in my case, technology, or, they're asking what the pros and cons are. But it can also be a moment of alienation by kind of minimizing or saying, well, that's just ridiculous. So I always try to at least engage to kind of meet the patient where they're at, understand kind of, what are their concerns? A situation like here, is it really that she's worried about the role of no adjuvant therapy because we got it all? And, maybe reaffirming the data and kind of understanding, what surveillance looks like going forward can really be the type of reassurance she needs, more so than, a prescription for the next medicines that she's not necessarily indicated for.
Yeah. No, I think in this situation, that's totally, exactly where she is probably. And, acknowledging that these are medications, as we'll talk about, that could be used in different situations, and how smart she is to come up with this question, because it really is a good question. What do we do about these potential options, and who are they right for and who are they not right for? But then also validating why she doesn't need them. And in this case, it's because she's done so well and she's gotten that PCR, and we can reassure her reasonably. So yeah, I think you're absolutely right. You do want to turn it into that moment of education and not alienation. That's really, really well put. Kristin, I didn't want to interrupt. It looked like you maybe had something to add as well.
I was just going to echo what everyone else said. And I think that the messaging is really critical when patients come to us with this, just as Kristina highlighted, validating what they're saying, framing it in a way that, they had a great response to chemotherapy, and how framing that in a positive light. And then also providing them with resources you've vetted yourself.
Yeah, 100%. So that's great. I think that's a great discussion. I think this is a great question that our patient has come up with. What about capecitabine and what about olaparib? And I think in her situation, it's actually a little bit easier and more clear cut because she's had a PCR. So as we'll talk about, she doesn't really qualify or need either of these treatments. But it is a little bit dicier and a little bit up for conversation in patients who haven't had a PCR. So we'll talk about that a little bit too. Just want to show this one slide that I created, kind of taken from some of the key points from the CREATE-X study. This was a study that, as you can see on the left, looked at patients who had stage 1 through stage 3B breast cancer, received neoadjuvant chemotherapy, and went to surgery, and then did not have a complete response. These patients then, after having not had a complete response, were randomized to either nothing, essentially a control group where the standard of care at that time was not to do any more treatment, but just to watch, or to capecitabine, which was the intervention in this study. And as you can see here in the triple negative patients, this is a trial that actually looked at HER2 negative patients as a whole. So there were ER positive as well as triple negative patients in this trial. But for triple negative patients, the progression-free survival as well as the overall survival was significantly improved by capecitabine as opposed to just standard of care monitoring. And so that became kind of an option for these women, and really the standard of care, and the only standard of care up until we had other options. So this patient, I would say, she does not need capecitabine. I think we can tell her that, that she would not have been even a candidate to enroll in the CREATE-X trial because she had a complete response. But I have heard the question asked, and I've heard it answered multiple ways since the KEYNOTE-522 data came out. What do you do about patients who, have not had a PCR? Do you give them pembrolizumab and capecitabine? Do you, how do you do that? And I think, we will still learn a little bit about what to do for each individual patient. But my thinking currently is, and Reshma, I'd love to hear what your thoughts are, is that for that non-PCR patient, given that the patients on KEYNOTE-522 who did not have a PCR did so much better with the pembrolizumab than they did, if they didn't get it, I would probably just continue the pembrolizumab in these patients for that 27-week period, and then have kind of a risk-benefit discussion with patients after that about whether to do capecitabine, or, depending on sort of their level of treatment fatigue, whether we hold off and let them be monitored just as they were on 522. So for this patient, no capecitabine, and a patient with non-PCR, I think maybe an area of further discussion.
So fortunately, I haven't had to make that decision because we had at our institution the SWOG 1418 trial, which was looking at patients that had neoadjuvant therapy without the inclusion of immunotherapy and went to surgery, had residual disease, and afterwards were given adjuvant immunotherapy. And in that trial, capecitabine was permitted. So the way we were doing it was we were giving the capecitabine first and then allowing them to enroll. So, again, an area that we really don't have clarity on.
Right. And that was how we did it. We had that study open as well, actually, and we did it exactly that way. We did the capecitabine and then we did the pembrolizumab. So, it was sort of a sequential thing. But now that that study is closed for enrollment, I think it will be an open question for patients. So very interesting. And then Reshma, tell us a little bit about olaparib. What is the patient's concern here and how do we address that with the current data?
So I think, again, just to drive home the point that you made earlier in terms of this patient in particular who had an excellent response to neoadjuvant and wouldn't really be appropriate to receive capecitabine. I think in this situation, in terms of the PARP inhibitor adjuvant data that we heard based on the Olympia trial, again, just to highlight the study design, these were really exciting data presented at the plenary session at ASCO, which were clearly practice changing. The Olympia trial specifically focused on germline BRCA mutated patients, but really looked at a high risk population. So if you had triple negative breast cancer, there was a requirement for residual disease after preoperative therapy. Again, our patient wouldn't have been eligible, or if they were enrolled after surgery, you had to have a tumor that was larger or had nodal involvement. And then for ER positive patients treated with preoperative treatment, there was a requirement for residual disease with a CPS and EG score that was greater than or equal to 3. And if you were enrolled after surgery, you had to have 4 or more positive notes. So again, recall our patient had a complete response, that she wouldn't have been eligible for this strategy. Patients were then randomized 1-to-1 olaparib versus placebo for 1 year.
Excellent. Yeah, that's a great, very informative slide and a really important study. I'll let you go on to talk about some of the results.
Yeah, so I think, here we were really impressed to see at this time point a difference, a 3-year invasive disease-free survival difference of 8.8% with the use of olaparib for 1 year in the adjuvant setting. And I think, for us, this has been in really practice changing, not only in the fact that now we should be offering patients this treatment, but I think it brings up the question of testing and making sure that we're not missing patients that are germline BRCA mutated. Previously, we were using the information to inform how these patients would be screened, including MRIs, testing family members, but now we actually have a treatment that we can offer them to reduce their risk. So I think it highlights that need to not miss these patients.
Absolutely. And I think really expands the opportunities for genetic testing for these patients as well, for triple negative and for ER positive patients in the early stage setting who might meet criteria here.
Mm-hmm. And overall survival was immature, but fewer deaths did occur in the olaparib arm. And of course, with longer follow-up, we're hopeful that we'll see a survival benefit.
Absolutely. Yeah. And I think, this is still young data. So the potential to see those curves, the gap between those curves widen is certainly there.
Mm-hmm.
So very exciting. And yes, you've got this fantastic plot here that really brings home the point that everyone is benefiting.
Sure. So, of course, the question comes up, can we apply these data to all subgroups? And for example, in this trial, there were fewer hormone receptor positive patients, but as you pointed out, Jane, across all subgroups, there was a benefit. You do see wider confidence intervals for patients with hormone receptor positive disease and those who had received prior platinum, but with the caution that the interpretation of this information should be recognized that they're small numbers here. So certainly in my practice, I wouldn't withhold adjuvant PARP here based on hormone receptor status or prior platinum use. And again, what I didn't include were the toxicity or safety data, which was something that I think we were all concerned about with regards to PARP inhibitors in terms of MDS AML rates, but we didn't see any hint that that was an issue. Of course, we'll continue to follow these patients.
Yeah, no, and it seemed to be, we had patients enrolled at our institution on the study, and I feel like the toxicity, both what read out in the trial and also what we see is that this is pretty well tolerated in this setting. So it's definitely promising and exciting data.
Mm-hmm.
So we're going to end this case. I know we only have like a minute left, but we'll end on a really good and easy note. This patient completes her radiation and her year of pembrolizumab, and 3 years later, she is NED. And I think this is a patient who at 3 years, given that she's NED from triple negative breast cancer after PATH CR, is very, very likely to be cured of her cancer and not hear from this again. So very exciting. I think that was a great discussion. So appreciate all of you being on. And we're happy to have been here and look forward to the Q&A.